So welcome to our afternoon session. I hope you guys all enjoyed the last few hours of the exhibit hall. I mean, you guys hear me okay? I got to move this around a little bit. But yeah, thank you for coming to our session on the elements of a value-based approach to providing complex rehabilitation technology. What this is coming towards the end of a 5-year grant that we were fortunate to receive from the National Institute on Disability Rehabilitation Research and Independent Living that really was focused on, looking at contemporary funding policy and how that could have an impact on people with disabilities. And so we wrote it up, looking at CRT, which is why we're all here. And we all know the challenges of what it takes to provide complex rehab and the policies that don't always match up with common sense or best practices. So we came up with 4 projects that we were going to put together and kind of investigate, do a little bit of a deeper dive into it. But to start out, there's no conflicts of interest that we have. This is funded by the federal government, but it's our opinions based on that. So jumping right into it, I just say it was a very fun project to work on because we had so many stakeholders involved, and we know sometimes that can get complicated, but really had a strong group of people, like-minded people who want to see policy change and want to investigate a little bit deeper into, what is it about policy? What is it? What can we change? And really take a good look at, what's going on around us. Everybody asks, like, what's going to happen in the future of CRT? We say, well, just look at healthcare in general. We're usually about 5 years behind. So healthcare has gone to pretty much what they call a value-based approach. I don't know if there's value to it, but that's what they're calling it. But it's a lot about accountable care now, a lot about payment models that are, per person per month kinds of things, where health plans and health systems purchase lives, if you want to look at it that way, and basically agree to take care of that person's needs, kind of at a lump sum. So our group was good. It was Michigan, Pitt, Ohio State. Carmen's right here. Sorry, I haven't introduced the other speakers. I'm going to let them do that when they get up here for the sake of time, but also the different stakeholder organizations. So especially people with disabilities. So we have United Spinal involved. We have INARTS involved from the supplier perspective, NCART representing industry. So we feel like, everybody had a seat at the table and everybody had a say in the process as we were going through it. So some of the things that inspired the work way back then, if you remember, AHRQ came out with that study about, what is the state of, clinical guidelines and practices related to CRT. This is just post Operation Wheeler Dealer. Some of you were around back then, but basically, the Medicare Power wheelchair benefit, exploded by like 400% within a few years. No one was really paying attention to it at CMS, but they felt after it all came to the surface that there was a lot of pressure from Congress and other government agencies to say, what are you going to do about this? So they started peeling back some layers to see, what is it that we do? What are the processes? And that's where AHRQ said, we've looked at the literature, we've done the gray literature, we've interviewed people, and we were finding absolutely no consistency whatsoever in how this stuff is provided, with very little oversight, and we're probably paying too much for these devices. Now, at that same time, when they're saying there's no guidelines, the RESNA best practice guidelines came out just about the same time, but didn't get put into that review, which was kind of unfortunate. But those of you that know the RESNA wheelchair practice guidelines, it's, right now it's 8 steps. It's going to be probably 10 steps by the time we're finished renewing the new version. But it kind of goes through that sequential process of what's important, what do you need to consider when you're providing someone with a CRT device. So that's kind of what guided us through this whole process, which is good. And we still continue to use that as the guide as we're looking at how practices and policy work together, and hoping that, policy is driven by practice, but unfortunately practice is still driven by policy. So just to skip back, 4 projects. The first one Carmen's going to talk about here in a minute. He took the lead on that, and that was a scoping review, dive deep into what is the state of CRT service delivery. The second one was looking at standardization of the assessment process. We're not going to cover that in depth. I know Rachel and her team are covering that project in another presentation. Project 3 was looking at large data analytics. What's the data telling us about how devices are provided? How long do they last? What breaks? When do they break? How much does it cost to own that stuff? And then the fourth project is to actually develop the elements of what that policy, what would be the elements of that policy, not the actual language, but what should it include? And Mariana is going to come up and talk about that. So with that, I'll turn it over to Carmen.
So I'm going to talk today about our scoping discovery review. As Mark mentioned, that was the first project. And I guess I'm so excited about it. I jumped right into it. I'm Carmen DeGiovane. I'll start there. I'm a rehabilitation engineer and assistive technology professional. I work at The Ohio State University, both on the academic side and the assistive technology center. So there were three parts to the project. There are three parts to the project that we focused on. And so I'm going to skip past the what is known and what is unknown and go right to the study question. And that was to understand stakeholder perceptions of the current state of the implementation. So the implementation of the CRT service delivery process. And you're going to hear me focus a lot on implementation because that's the thing that really stood out to us during this project. It wasn't so much the actual steps that Mark just talked about of the wheelchair service delivery process, but it was really about the implementation of it. So at the very bottom of the slide, we had two different projects we worked on. The first was the scoping review, and the second was the stakeholder survey that we did. And we took that stakeholder survey and looked at it from two different aspects. One was a quantitative aspect, and the other one was a qualitative aspect. So the scoping review, I've talked about this previously. We had two articles from the scoping review that came out recently, both in the Journal of Disability Rehabilitation, Assistive Technology. And the key findings that we had from the scoping review was that the service delivery process includes ambiguous guidelines. So even though we have these 10 steps, we need more detail on what those steps look like and how they can be implemented. There was a clear indication of a lack of expertise out in the field, long wait times, lack of repair service, limited consumer training on the use and the maintenance of the devices, lack of follow-up, and then there's a coverage policy that does not consider the overall functional needs of power wheelchair devices. The needs of people with disabilities. Sorry about that. And you're probably looking at this going, okay, there's nothing here that we haven't been talking about. And the other key theme that you're going to hear from us today is, yes, we've heard this anecdotally for years, and the whole purpose of this project was to quantify, to actually get it down on paper and down for policy makers to be able to look at this information and hear about it. The second step that we did was a stakeholder survey. And you may remember this from 2 years ago that we were asking people in this industry to fill out the survey. And people always ask us, when do the results come out? So the results are out. The results were published recently in Disability and Rehabilitation Assistive Technology Journal. But the key findings from this, from a quantitative standpoint, is nobody's happy with the implementation of the service delivery process. Only 5% of the stakeholders that were surveyed felt that the funding and procurement process was satisfactory. Less than 10% felt like the follow-up, maintenance, or repair were satisfactory, and the list goes on from there. So the survey reinforced what we had learned from the scoping review, and it also gave us a sense of where we could start working when we look at a new policy. The second thing, the unexpected result of the survey was that we received over 300 comments from people. So people were not only willing to fill out the survey, but they were very passionate about what is going on in the wheelchair service delivery process. We had 300 comments. From those comments, we went through and broke them down into 460 sub-comments with over 600 tags. So that's the way we turn this qualitative data into a quantitative form. Undeniably, most of the comments were negative in nature. There was 81% of the comments were negative, 10% were neutral, and 9% were positive. From these comments, we started to see themes or categories that came out of it. The primary theme that came out of it was the need for standardization. People wanted to see this, no matter what the stakeholder group, people wanted to experience a service delivery process that was similar no matter where they were geographically or what type of clinical service delivery program that they went to. And so this is up on the screen as a graphical form of what the different themes look like. So standardization was the key theme at the top, the primary theme. The secondary themes were funding, stakeholder knowledge, quality, client-centered care, and geographic access. And then we went into the tertiary themes from there. So the key takeholders from all of the key take-home messages from the qualitative services, the comments, which was actually a little surprising to us, addressed every area of the wheelchair service delivery process. It was overwhelmingly negative. Over 40% of the comments focused on funding. And it gave us an idea that there is a real need to implement, to revise the implementation of the wheelchair service delivery process. And so I go back to that slide that I started with. I glossed over a little bit of what is known, and we got that information from the scoping review. What is not known, we feel like we have a better understanding of what is now known. It was before what was not known, now what is now known. And that's that the implementation is not working the way that we wanted to. And now we have a better understanding of what is the stakeholder sentiment around the service delivery process. And then finally, the key takeaways. The CRT service delivery process is well described in the literature. I didn't focus on this earlier, but one of the things that we thought we were going to have to go into peer-reviewed journal article and gray literature, and we really didn't have to go into the gray literature a lot. There is a lot of peer-reviewed journal articles in the area of wheelchair service delivery. The second thing is no one is satisfied with the current implementation of the CRT service delivery process. And we fully believe that there's opportunities. And so we're going to talk about those opportunities in projects 2, 3, and 4. So I will pass it, I think, back to Mark.
All right. Yeah. So what I was saying is, like, project number 2 was to standardize the assessment process. So those of you that are practicing clinicians, do we need standardization? No, you get both sides of it. Some of us say it's an art. We can't standardize it. Everybody's different. Everybody's special. I get that. I get it. That's called the subjective. But what about the objective? Right? So when you think of reviewers, for example, wouldn't it be nice if you guys would just all write everything the same way? And I'm like, yeah, I agree, but we're not there yet. But, we can be inspired by other areas of healthcare. It's not the Asia, it's the INSKI now, like the Asia scores, A, B, C, D. I know that's just for spinal cord, but really what they're trying to work on here is come up with a battery of available standardized tests that you could use to maybe come up with an index or a classification system. And, one of the things that did inspire us as we've been doing this and still does is the orthotics and prosthetics separate benefit category, where they have the function levels, the K codes. Wouldn't it be nice if we had something similar? Because the payers and the practitioners, although it's not perfect, does help to communicate to someone that knows nothing about O&P to be able to say, okay, they're a K1, a K2, 3, 4. Now we understand, and therefore they would qualify for a certain type of device. Whereas in CRT, do you have a neuromuscular diagnosis to get a group 3 chair or a certain cushion? It just doesn't always work. But CMS, in discussions over the years with them, it says, we're going to use diagnosis until you guys come up with a better way to do it. So I think that was a wake-up call for us. Let's not wait around for the government to tell us what to do. Let's try to do it ourselves. So Rachel and team has done a good job. They've come up with tools. I don't know if any of you were at like Vancouver in 2018. We started that process asking people, how many of you use these tools? Are they helpful? Are they not helpful? So that process is done, and now they're getting into validation, and it's looking good. I'm going to move into the data set analysis, and there's been a lot of different presentations at this symposium and past ones about what some of the outputs are looking like. But we came up with about 5, 6 different data sets, and each data set doesn't tell the whole story, and at least not yet. Corey's going to take care of that for us when he gets up and talks in his presentation afterwards. But the FMA, we've had that now for quite a few years, and we're up to like 16, 17,000 cases. It's giving us some good information, but it's all self-report. It doesn't get granular, and it doesn't get granular on purpose because we want it to be usable in the clinic. We don't want to give clinicians more things to measure or document. So we're trying to get some general information. And this is where the the CMS 5% public use file or limited data set, as it's called, that gives you everything. Like just so much stuff, it's mind-boggling. So I'm not even going to talk about it because Corey does, that's his area. Labor Tracker Wheelchair Repair Registry was something we got a hold of in a previous RERC on wheelchair standards, and you've seen some presentations on that at some point. But it tells us basically it gives us a lot of claims data on wheelchairs, and what we do know from that data set is how old the chair is, the serial number that's on the chair, the brand, so forth, but we know nothing about the user. So you see what we're getting at here is each data set has to inform the other data set without really being able to collapse it all together because they are independent of one another. And we don't even know if some people or devices show up in the different data sets because it's so de-identified, which it has to be. We've also looked at Permobile's connected wheelchair data. What we got from that was basically distance traveled, and Hanju is going to cover that. But again, we don't know anything about the user, where they live, what they do. It's just telling us how far people are traveling in their devices. NSM worked with us. They gave us some of their data. We crossed that with wheelchair repair data and found some, consistency, which was good to basically reuse. That's what we used it for. So the timelines for when things break or need replacement are consistent across 2 data sets. And then we looked at our own health plan data at UPMC Health Plan, which was very interesting because not only did they did de-identify it, but they also gave us how much we've spent on CRT in an 11-month period, which was mind-boggling. So, so FMA gives you a lot of demographic information, like I said. So, we're up to 16,600 cases now. Some of you in the room are contributing to that data set. Thank you very much. Please keep it up. It's been very useful. We're looking from time to delivery to follow-up is like 81 days. We've actually seen that number go up a little bit now. I can probably speculate why. It's denials by certain companies. The average year of birth for a CRT user is 1961, injury 2004. I mean, these are just kind of fun facts. We're not looking at it, but it's just showing you that we can calculate things fairly quickly off of this data set. Everybody says, who do you see? What kind of patients do you see? What's their diagnosis? Here's your top 10. Your most common one, everybody clicks that box called other. So 23, 24% is other, but that's, any neuromuscular condition that may not fit well into the other one. So cerebral palsy, spinal cord injury, multiple sclerosis are, stuff that we kind of know intuitively. But what's nice about this is if anybody asks from a policy perspective, who is it that you're treating? And it's like, well, we're treating people with the most severe disabilities is what we're treating. And even in here, we have a lot of people with, the cardiopulmonary disease. A lot of them are mobility users, CRT users, but probably all end up in group 2s when they could probably use a group 3. Interesting about the 10 items of the FMA, probably a lot of you are familiar with it. We're looking at, time 1, which is baseline, and this is time 2 across thousands of people. Scores are going up. They're going from like 29 up into the upper mid 50s. We do now have some data, believe it or not, at time 10, which I don't remember what number is that, Rich? 5 years? 5+ years. Yeah. So I think we have 9 people or something. 5. Oh, I think we're up to more than that now, but The idea is if we can get a few thousand people to go through a 5-year life cycle of a wheelchair, that's going to be some pretty powerful data to see what does happen. And the reason I think they stay high is because these are folks that are being checked in on a regular basis. They're getting telephone follow-ups on a regular basis. So their scores are probably staying high because if you listen to Matt Yankee's presentation this morning, he talked about what it's done for their clinic at Ohio State. You can catch things before they become catastrophic. So not only are we informing policy here, we are informing practice. We also know what funding source they have, but again, not specifics, but just general. Medicare is still traditional Medicare is still the largest, and that's most recent. Medicaid, managed care. But what we did just for fun, this is not published yet, but I want to share it because I think it hits home with a lot of what's going on right now. When we started out in 2018, about 30% of the sample was showing up as Medicare or Medicaid or dual managed care. That's now up to 60%. So that's well over half of CRT users are now on a public insurance that's managed by a private company. So that's your Medicare Part Cs that you see advertising on TV for the free food and the free gas, but they don't mention whether you could get a wheelchair. So to me, I'm not alarming anybody, but I'm just saying here's the trend. So more managed care, more private equity, more competing on pricing, and we're seeing a shift in manufacturer, a rise in failures, repairs, and nobody to fix it. I know that sounds grim, but that's the way I'm thinking. There seems to be a relationship here. Again, just looking at it, eyeballing it, we're looking at falls, we're looking at pressure sores, just without doing the analysis on this one. And Corey's covered this one too. We are reducing falls, we are reducing pressure sores. Statistically, where it is, that's where the publications come in. And this was a study done recently, or not recently, from another student that we wanted to know, from time of assessment to time of delivery, and what do these timelines look like? And I think we presented this before. This is published, but your national average is 100 days. And obviously, as the devices become more complicated, the longer it takes. And why is that important? Well, it's important for a lot of reasons. It's to inform us, it's to inform payers, but it's also to inform the people we serve. How often do people say to you, well, how long is this going to take? And I can faithfully say now in clinic about 100 days or 80 days, or if you're going for a group 4, it's going to be 140 days. So you can help make that decision for yourself. If you want to pursue the group 4 chair, we'll support you on that, but it's going to take time. So repair registry is interesting. Just one of the first analyses we did on it was just to see, well, we know what breaks, but do we have quantifiable or quantitative data that tells us that? And no surprise, it's the wheels, the casters, the arm pads, all the stuff we see in clinic that breaks, right? And in power wheelchairs, it's obviously going to be batteries and electronics as well as all those other features. And that's all been published. Now, our other Mariana did present the overall qualitative analysis. We interviewed a large sample of stakeholders to ask them their opinions on the whole repair process. This was a study that just looked at the 4 users of the devices to see what their perspectives are. And basically, just like what Carmen was saying with the other surveys we've done, we're starting to hear the same story over and over again. The system's broken. We can't get our chairs fixed. The process is not conducive. It's just sort of evolved for some reason, some way, to the point where this is just, the equipment's expensive, but if I look at the time we're spending and the energy, things we don't have, like Jeannie said, it's energy and time. Those are two things that people with disabilities just don't have. Neither do we as clinicians or suppliers, but we've created this process. So it's good to get this documented. So when you go, like Carmen's saying, when we're going to talk to legislators or policymakers, they're like, is this really a problem? And we say, yeah, it really is a problem. And they're like, well, how do you know? Well, we just know because we do it every day. And that's true. But now we've got ways that we can show that it really is a problem. So, um, so that was a quantitative study, looking at multiple stakeholders. That was discussed a little bit this morning, but the same thing is happening. I'm going to have, which one is this here? The estimation of when things break. And I'm going to, instead of me presenting this, I know Matt Kim is right here. So I'm going to have him just come up and do justice with it. So you can talk about your electronics thing in the quick minute here.
Thank you, Mark. Yeah, my name is Matt. I'm a former student under Mark and Rich, and currently I'm working as an ATP at New Motion. But I collaborated with them on a small piece of this bigger picture to quantify power wheelchair electronics and the lifespan, and kind of, give some data for suppliers, funding sources, and users to really consider and to have available to them. So just to kind of summarize the findings that we had, we did 2 steps of statistical analysis, a univariate analysis and multivariate. And really, we were looking at a set of retrospective data on wheelchair service data from power wheelchairs in the US. And we were really looking for, one, what is the average or median lifespan of electronics? And also, what are the factors that contribute to variability, if there is? So first, we found that the median lifespan of power wheelchair electronics was about 2.5 years. So something of note, since Medicare will fund a device every 5 years. And we looked at a couple different variables to see if there is some variation in the lifespan of power wheelchair electronics. And we found that, in particular, a distribution year in 2018, distribution year in 2017, and being a group 3 device were among the statistically significant predictors of a greater risk of failure. And we also found that manufacturer D, that was anonymized here, is a marginally significant predictor, but since it didn't meet the alpha level, but still of note for our study. So these are some of the findings that just help to put some numbers, I think, to the story that a lot of us are familiar with, to share with insurance and everyone.
Great. Thank you, Matt.
Thank you, Mark.
And Matt's study was also a replication of another study we had done just on batteries. And interestingly, it found almost the exact, not exact findings, but same kinds of things. What they found was that battery, the life cycle of a battery depends on a lot of things. Manufacturer was one, and then also the climate where the device is used is another one. So all I'm getting at here is the data is starting to trend towards parts do fail, and they fail somewhat predictably. So this whole repair issue from a policy perspective, why are we getting prior auths for an oil change? Okay. Like, why can't we just build that into the cost or assign a cost to it so that when a person's ready for that service, it's, less of this back and forth, and rather, yes, well, that makes sense. Let's maybe bring chairs in every year, maybe bring them in every 2.5 years when they hit their half-life. So I'm going to turn it over to Rich.
Well, thank you, Mark. So again, my name is Rich Shane. So I have the privilege of actually working with everyone around here related to this policy drip project. So I get to manage and operationalize that big first slide that Mark showed that had about a dozen people on that slide. So I get to obviously interact with all those individuals and kind of strategically place the projects that Mark outlined, those 4, about prioritizing what's going to happen in terms of aims and projects and specific analyses as well. And so this is one study that we had done, and this is at the time when the NCD was happening for seat elevation. And so I remember talking with Julie Piron. I think I saw her walk in the room, maybe not. But at that time, we were looking at a specific publication that we could put into that NCD related to seat elevation. And as Mark pointed out, with our functional mobility assessment registry, we're able to pool lots of different factors into that kind of outline of inclusion criteria. And so we did have data on a couple of hundred individuals. What we wanted to showcase was the benefit. Actually, this is not the seat elevation. This is baseline ATP. I take that back. We'll go backwards. Sounds good. My apologies. So this is the functional ability, employment, and safety for seat elevation devices. My apologies. So this is basically looking at a year sample of data. So basically we had exported, I would say, about 1,500 individuals who received a seat elevating device at their delivery. And instead of just looking at a baseline or a follow-up, we studied these individuals for a year and a half. And again, as Carmen pointed out, what I'm going to present from the bullet points is probably aha moments, right? It's not anything that we already don't know, but it's now being published in literature that we can cite as well. So what we found was there was a significant higher total FMA score. So the FMA is based on 10 specific items. And so we took all 10 items and looked at that total score. But within the functional ability assessment, we can look at specific topical areas. And so one of them would be reach and or transfer. And what we're showcasing that with the seat elevating device, we have higher scores for reach and transfer. We also looked at other non-functional ability outputs related to higher employment rates, which is what we want to see. As Mark pointed out, we also had found that there was less falls without those who had seat elevating devices as well. And most importantly, for safer transfer. So again, the larger data that we have access to, the better ideas that we can have from a published literature standpoint to cite these types of references. I'll just go backwards. So this specific slide is looking at baseline with ATP compared to individuals with no ATP involvement. So when we started this project with the FMA, with the Van G. Miller group, we wanted to look at where we are with the data from the first few years. We developed a specific service delivery process on how the data was going to be analyzed, how the data was going to be stored and collected. And what we wanted to look at, the benefits of having the ATP versus the non-ATP. We all see the benefits of having RESNA and the credential, but when you look at the literature, how many actual studies are there that show the benefits of that credential as well? And so what we wanted to do is basically just look at the baseline sample first. And so obviously the baseline is that darker purple, and then with the ATP is, I would say, that bluish color as well. I know it's a little granular from my view to your view. Again, this is just baseline scores. So I know they're not as high as Mark had pointed out. What we want to do next, and then what we're doing currently, is we're looking at a 5-year period. And so we're going to look at this baseline, compare it over a 5-year kind of assessment process, following the best practices outlined by RESNA Service Delivery Guide and having this constant follow-up. And so with the FMA registry, for those who are involved in it, they actually have 21-day follow-up, 60-day follow-up, 90-day follow-up, a year, and then annually. And so now we can show the longevity of the benefits of individuals who are using and obviously have the credential ATP as a clinician and the supplier role as well. Because everyone who is involved with the registry are all ATP certified clinics and suppliers who are all enrolled in that process. This is me as well. So the other aspect to this as well is what happens to those individuals who potentially are in the registry, but what happens when they are not continually followed up? What is happening with them when they say, you know, are they lost to follow-up? Are they opting out? Are they no longer participating? So we wanted to kind of gauge, why are people not staying in the registry as well? And so these are just some common elements that we found, is that the equipment was not delivered because of funding issues. Lost in contact was the largest one here. They unfortunately deceased or returned equipment. But I think the important factor here is that how important the ATP is in the whole entire process, right? They are a member of the whole entire team, and they're the ones who are actually having that contact with the client. Sometimes clinicians see those individuals for the first evaluation, but having that supplier ATP following up over and over again, that's the touch points that we want to make sure are constantly happening. And that was a kind of another product that happened with this study as well. And all this literature is published as well. So I think I'm going to turn this over to Corey for falls. Or not, I can do it if you don't want. No, you come on up, Corey.
Hopefully all of you have met Corey, by the way. He's our only health economist.
Don't tell him that. So I didn't know I had this slide, but that's all right. Hi, I'm Corey Morrow. I'm an assistant professor at the Medical University of South Carolina. I'm also an occupational therapist, and as Mark said, I'm a health economist. So treat me nicely. So this was a study that if you were at Matt Mesros's presentation yesterday, we went through this a little bit. No, I'm sorry, this was the baseline one that got published. So at baseline, um, about half of our participants reported some kind of a fall before they got their new wheelchair. And I presented this at the last ISS. Now I recognize this. And we kind of categorized all of our different diagnoses. As we saw, there was a lot of others. There was a lot of neurological disorders. And so we're trying to bucket them into different ways to increase our ability to do different analyses. So we've kind of moved them into progressively acquired, and they were the most common participants who reported a fall. So these are patients who have not necessarily gone through the hospitalization process as someone who's had a stroke or spinal cord injury. So this is maybe grandma's been falling more frequently, and we're not really sure what to do with this patient, with this person. And so we're going to go down to Walmart and pick up a wheelchair and then realize that's not working very well. And then somehow they end up in this FMA UDS. So if you went to the presentation yesterday, you saw that we now have a 1-year follow-up of this as well. And trying to get away from diagnostic driven prescription, particularly for our group 3 chairs, we're trying to use statistical methods to rule out both age and diagnoses as predictors of falls, so that we can kind of show the value of this specialized wheelchair assessment / ATP involvement over the year. So that's what I just talked about right there. So we did reduce falls. And as Mark was saying and Rich were saying too, we also did an analysis at 1 year for FMA scores, so mobility related satisfaction. And we saw again improvements in that area, both in all the individual categories and the overall aggregate category. And this is actually the next presentation. If you guys are interested in Medicare claims data, super exciting information for about 3 of us in the room at least. So that's fantastic. But I enjoy it, so I'm going to talk about it in the next hour. And I think I have some pretty interesting things for you nerds out there, in looking at similar things that we have been talking about today, but triangulated with the Medicare population. So it's much different than what you see in the FMA UDS, because it's everybody. It's not just people who have access to a seating mobility clinic. And so it's a little bit more nationwide representation. We'll look at replacement parts and costs over a 5-year period. So I think that's everything for me. Distance traveled. Hanju.
So, my name is Hanju Zhu, Dr. Schmeler's current PhD student. And yeah, we also collaborated with Promobile because it equipped their devices with connectivity feature. The sensors on the device collect data such as distance traveled, battery charging, and the use of power saving functions. And then those data were sent to the cloud servers and managed by the fleet management platform. So we analyzed the whole year data set from 2022, specifically focusing on the US area. And so we got a data set sample of 3,058 power wheelchairs. So the results finally showed Promobile power wheelchair users drove on average 1,365 meters per day, or 0.85 miles in 2022. And in terms of number of use days, meaning the days when the user drove more than 5 meters, and Promobile power wheelchair users used their device on average 301 days in 2022. If you look at the table in the lower left corner, and you can see the mean daily distance traveled across different device models. As you can see, the M5 had the highest mean daily distance traveled, and M3 had the lowest. And they roughly have the same mean number of use days. And then move forward to the lower right side, we further categorized those devices into group 3 and group 4 based on CMS rules. And in total, we had 2,615 devices. And from the statistical analysis, group 4, which had 1,783 meters, it had a significantly higher mean daily distance compared to group 3 devices, which had 1,333 meters of mean daily distance traveled. And again, they roughly have the same mean number of use days, and there's no statistical difference in terms of the mean, in terms of the number of use days. So that's it. I'm going to turn it over to Mark. Thank you.
All right, I think Mariana, you're up. So Mariana gets to tell us, how does this all come together?
Right. Good afternoon, everyone. My name is Mariana. I'm an occupational therapist, and for the past year, I have been a research fellow at the Center for Assistive Technology, so within the Seating and Mobility Clinic. Naturally, I've been working with Mark and Rich for the same amount of time and with everyone on the team. So as a new clinician and a new person coming into this field, it has been a fantastic experience and a great way to learn more about the field in general. So this last project, we are almost at the end of our presentation, is simply putting together all of the findings that we've had from the past 4 years of this grant. And so ultimately, for our goal to improve service delivery, we must do so by informing policy. And so this is a start to it. And this is what the final project was about. This has been stated many times throughout this presentation today, but ultimately we've known that the service delivery process is outdated, is inadequate, and is not in the consumer's best interest. Not only do consumers say this, but also clinicians, suppliers, and many other stakeholders, as they are constrained by policy standards. And so how can we move towards a more equitable policy? Then we have to consider all of these perspectives and consider how all of these stakeholders interact in order to create a policy that represents everyone's work and also is in the consumer's best interest. And that's exactly what we wanted to promote in this project. So we wanted to do so by taking a step back. So instead of informing or instead of proposing a new policy, we decided to develop attributes of a new CRT policy. So these attributes are simply characteristics of what we wish to see in a new policy and what new policy should represent. We developed these statements into a survey, and so we sent this survey out to many stakeholders in this field, and finally we compared and analyzed responses. So this was a quantitative study. We did this in 3 very brief phases. So we identified these attributes. Subject matter experts in the field ultimately held weekly meetings to come up with these attributes as they were based on the findings from previous presentations and previous studies. We assessed content validity. So for clarity and relevance, we used input from the same members of our DRIP team to make sure that we were trying to remove as much bias as possible. And finally, the final statement ended up being a 10-statement cross-sectional online questionnaire. So it was deployed in this 3rd phase. Respondents, so stakeholders, had to rate their level of agreement with each statement based on a 6-point Likert scale. So ranging from 1, we completely disagree with this statement, all the way to 6, I completely agree with this statement. We had very positive we have very positive results, meaning that we had a lot of stakeholders involved in these answers. So we reached out to suppliers, clinicians, consumers and caregivers, manufacturers, technicians, and we had a payer group. However, this group was removed due to a lower response rate. And we saw that for the 10 questions, we had 6 statements that had significantly different responses in the Likert scale. And before we get into this is the next 2 slides are simply a representation of how we decided to come up with these attributes. So I'll just take the very first square, for example, but if we were to develop an attribute based on standardized assessment, based on documentation, so we would develop this attribute based on findings from our first project, but we will also know it based on experience. So we know that suppliers complete some type of standardized environmental assessment, and we know that consumers really need a comprehensive assessment as well. So this is just an hypothetical explanation of how we developed these attributes, and the topics are on the left. So these next two slides are ultimately the 10 statements that were included in the survey. I will not go over them one by one. If we have time at the end and some of you may want to read some of into them, then feel free to say. But basically, so for example, the first statement said the components of the CRT service delivery could be completed by telehealth. Respondents have to express whether they completely disagree with this statement or if they completely agreed with it. And so what were our findings? Like I mentioned earlier, we had significantly different responses in 6 out of the 10 statements, but what was more important is that the consumer caregiver group was in this significantly different response. So consumers had significantly different responses from other stakeholders in 6 out of the 10 statements. Ultimately, these statements were related to service delivery process timelines and expectations, about if devices should be informed with regular maintenance, about having collaborative discussion with the consumer, especially during assessment, and assessing their comprehensive needs. So overall, these statements simply relate to areas that could be standardized within the service delivery process. Like we said, standardization is sort of a controversial topic, but these areas certainly could use more guidelines within them. And so that was one of the main findings, or 4 out of those 6 statements. And then the other statements simply related to any financial incentives for successful outcomes. So again, there is more information needed as to how we will carry out any sort of financial incentives, but ultimately this just provides an accountability measure and to ensure that steps within the service delivery process are being carried out correctly. Now, what happened to those 4 statements that there weren't any significantly different responses? So ultimately, in these statements, we saw that most stakeholders actually completely agreed or even mostly agreed with these statements. And these statements were related to the implementation and reimbursement of steps in the process that occur after the delivery. So that step of follow-up, maintenance, and repair, a lot of stakeholders really agreed that these steps are so necessary, but perhaps demand adequate compensation to complete them. But ultimately, the need for follow-up services was just what every stakeholder said. This is exactly what needs to happen, and this is what a new policy should include. And we just interpreted this as this is probably one of the biggest priority areas for new CRT policy development. In conclusion, we have consumer-focused policy changes, but these are only attributes. Again, we didn't propose a new policy in itself, and we do need more information and investigation to determine how we can start implementing these changes and ultimately if they're effective or not for all stakeholders. And this is all written, and it is currently under peer review. So that was the end of R4, and there is also a qualitative analysis, and I will leave Hanju to explain.
So except for the 10 statements in the survey, we still have the last open-ended question. So we conducted as well a qualitative study quantitatively. For the last open-ended question, we had 123 participants answered that, and we were able to code 110 out of them. In total, 110 participants, 47 consumers or caregivers, 30 clinicians, 8 manufacturers, 21 suppliers, and 4 technicians. epistemic network analysis was used to look into stakeholders' preference on attributes of a new CRT coverage policy based on RESNA's wheelchair service provision guide. And the results showed follow-up maintenance and repair was perceived as the most, it's actually its most frequently mentioned attribute, and it was most likely to co-occur with other attributes across all stakeholders, meaning whenever a stakeholder mentioned an attribute, it is always the most likely for follow-up, maintenance, and repair to be mentioned as well at the same time. So that's the final conclusion, and it's still under internal review for this manuscript. Thank you so much. Thanks.
Thank you. All right, well, I think that's the end of the presentation. We do have some time now for people to offer any questions or comments to any of the work we've done. And like we've said, this is really taking a kind of a deep dive into what the issues are. And I think what we learned along the way, we thought, hey, we can just write a whole separate benefit category for CRT by the end of this project. But as soon as we got into it, we recognized that implementation science really needs to be applied to these attributes. So we have them. We know why we have them. Now it's a matter of what could this look like, or how could we actually put this into practice? And that's the future work that we're looking hopefully to do. So yeah. Any questions? Yep.
I love this work that you all have done. My question is, so much of it has clinician input, but it has an emphasis on the separate benefit category. Have you all explored or discussed how, I have a loud voice, but how this might merge with the clinical billing process?
Yeah, we just spent, and actually, Mariana, what time's your presentation tomorrow? Because one thing we learned along the way, especially in some of the comments people were making, yeah, sure, maintenance, repair, that's a big issue. But guess what, clinicians? And now that I'm back in the clinic, I quickly started looking at things, and of course, we switched, leadership. And of course, every time you run a wheelchair clinic and you switch leadership, what do you end up doing all over again? Explaining why you exist. Okay. Yeah, it's I don't want to give away what Mariana is going to present tomorrow, but no matter how hard let's say we're not slackers, okay? We work very, very hard, but our time is not billable. Our billing codes don't reflect what we do. Our documentation is not reimbursable. So there's just a lot of issues. So future work that we're writing up, that's the top priority. If you can't take care of the clinicians doing the work, what's the point is the way I look at it, or just accept that we won't be around. All right. Well, there's other things we can do that are a lot easier, and we can go home at a normal hour. No pajama time in front of Epic at 11 o'clock at night on your laptop. So yeah, but thank you, Kara. I'm glad you brought it up.
One piece that continues to be a problem when I'm meeting clinicians and talking about follow-up specifically, and Teresa, you spoke to this a couple of years ago in a really great session, is, what do you do for follow-up along the continuum of care? You're speccing out this in inpatient, who's asking, and hopefully we all are asking, whether you're a supplier or a clinician, where's follow-up going to happen? How are we going to connect them to? Who's responsible to make sure? And I think that's a chronic problem that there's really no easy solution, but to continue to talk about that is part of the problem. And then the other piece that I'm curious about is with the value-based healthcare, one opportunity is in the home health sector and in their OASIS intake and how their reimbursement is structured. There's a real opportunity for CRT to help with their scores, but home health therapists are not aware of how to use CRT. So I think, in terms of, we've been doing some education about that, but now we're at that final 2-year mark where finally they're getting their reimbursement scores for the first 2 years. And I think we have a really good opportunity because they're seeing people earlier, they're seeing people more, impaired. They're seeing people come in with lower level chairs. They don't know to change them out, and they can really improve their reimbursement by using CRT. So I'm just curious if anybody in the room knows how we did with value-based healthcare and home health in the last couple of years.
Yeah, anybody have I don't work in home health, but that sounds like a good question to me. So, yeah. The other thing that came along the way that I'll just throw out there was, yeah, we have all these great attributes and great ideas, and we've talked to suppliers, manufacturers, and even our own health plan, who, they are forward thinkers. And there's one particular gentleman there who's really wants to create like our own version of like what Jeannie does in New York with ICS. And he just said, this is all good stuff, but implementation is going to be challenging. And the other thing too, everybody's going to revert back to, well, Medicare, this is Medicare policy, and we are required to follow Medicare policy. And Medicare policy is not designed to do anything cool, all right, or creative. So that's why maybe it's before we can start going to managed care plans and saying, hey, look at all this cool stuff you could be doing. Well, the first thing they say is, how much money is this going to save me today? Because people switch plans every year. I don't care if you're saving money downstream, because they probably won't be on our response. They won't be our responsibility in the future. So that's another challenge. So that's why we're looking at it as maybe the approach is to get CMS to write the policy and then push it down to the managed care plans. I don't know. We don't know how that's going to look yet, but that might be the approach.